Hi, everybody. I'm looking out at the Charles River and all of the trees are blooming. So I know that spring is definitely coming. It may be chilly and it may have been gale winds last night, but it's beautiful today. I'm so happy that we're going to be having this session on hearing health today. But before we get started, I have just a couple of announcements. One, I'm delighted to announce that MGH has received age-friendly health system status, meaning that we think about the 4 M's. And what are those 4 M's? What matters most? And that means what matters most to every person about your specific health and your goals of care and what you think about your end-of-life care and across all settings of care in the hospital. It includes medications to the extent that they are right for you or that they're interfering with the other 4 M's, which also include mentation and mobility, and I'll get to those in a second. And mentation, which is about your ability to have good cognition. So it deals with depression, delirium, and dementia, or loss of memory. And the 4th M is mobility. And that means your ability to get up, get around, go where you want to go, walk, and avoid falls. But what matters most to you guides what you want in all of those other realms. So we're now addressing all of those things at Mass General Hospital, throughout the hospital. We also have developed, we can tell you more about this at another time, but ID cards for people who are care partners for people living with dementia that say things like, I am a caregiver for a person living with dementia, and that person may be confused and may not remember important information, and it's a disability and we need your support. Or I am a person living with dementia and I may sometimes be confused, and this is a disability and my caregiver is essential to my medical care. And make sure that you talk to them too. So that's another wonderful thing that we're doing now, just to remind you about that. And now it's my pleasure, as it always is, to introduce to you our medical director, Dr. Matthew Russell, who is going to fill you in on lots of new goings on in the geriatric section here in the.
Excellent. Oh, can you guys hear me okay? Okay, because we lost Sharon's sound there for a second. Good afternoon, everyone, and thank you for this wonderful turnout. I don't want to take too much time because I'm really hoping that we can all get to this content. But as I'm sure you know, we have actually managed to grow our team here at geriatric medicine. And with COVID, we've had the staffing turnover that other industries have experienced. So I'd just like to introduce our team and some new faces that you might be seeing when you come to see us next. So I'll start with our fabulous medical assistants. So I see them. Give us a big wave. There's Raquel Delirio, Marina Rivas, and Stacy Maynard. So we're thrilled to have them. Our patient service coordinators, they're the folks that are the first folks you speak to when you call. Well, we've had our longstanding Deb Suda and Aaron Techie, and then we have some new team members, Vanetta Cumberbatch, Jody Jones, and Marissa Russo. So give a wave. Excuse me. And now we also have our new practice manager, who I believe is, yes, there he is. Okay, is Luke Cogswell. He comes to us from a practice at Newton Wellesley Hospital. We're thrilled to have him on board. And lastly, we have our newest physician addition is Dr. Katherine Hanley, who's coming to us from Milwaukee, Wisconsin. And if we could all just give a big clap for our new team. We are beyond thrilled that we are fully staffed and appreciate your patience during all the transitions. And it is so thrilling to work with everybody. Now with that, I'm going to pass the baton back to our moderator, Susan Edgman-Levitan, who'll go through some of the basic housekeeping stuff.
Thank you, Matt. It's wonderful to see everyone. I think at some point I'm going to do a pop quiz and ask somebody else to give the instructions for how to be on the Zoom, because I know you all could probably recite it by now.
Susan, I totally messed up. Sorry, I totally messed up.
Oh,
I completely forgot to introduce our new triage nurse, Susan.
Go right ahead.
Jennifer McGlynn. I'm so sorry. I just was like, I thought I had gotten everybody, but I didn't. So Jen, sorry about that. And thank God Karen Parmenter told me. Welcome, welcome.
Thank you. Thank you. So I am just going to go through quickly the directions for the Zoom today. I'm Susan Edgman-Levitan. I'm the director of the Stokel Center for Primary Care Innovation at Mass General. And I just want to review the housekeeping rules quickly. So everyone on the call is muted to eliminate any unexpected background noise. We don't want to interrupt our speakers. To view the main speaker on your full screen, go up to the right-hand corner of the Zoom, and you can either select the gallery view where you see all of us, or you can click on speaker view and you will only see the speaker or the slides. If your picture becomes jumpy or out of sync, click stop video in the lower left-hand corner where you see the little video icon, and that usually helps speed up your internet connection. We really want you to ask questions. We've got wonderful experts today, and so for that, please use the chat feature, which is the button in the center of the bottom of your screen along the bottom ribbon. And please do not share or ask about any personal medical questions in the chat, because anything you put in the chat can be read or seen by everyone. However, if you do have an important medical question or any medical question, please reach out to your doctor or your care team directly. And we'll do our best to answer all of your questions. So with that, I want to introduce our speakers today. We are very lucky to be joined by Miss Emma Alsher, who is an audiologist at Mass Eye and Ear, which is affiliated and part of Mass General, and also Dr. Elliot Kozen, who is an otologist there. And they are going to be talking about the work that they do to identify hearing issues, to support people's hearing, and to give us advice about what we can do to protect our hearing or what we can do if we think we may have a problem. So with that, I'm going to turn it over to Emma and we'll get started.
Hi, everyone. Nice to meet you all virtually. My name's Emma, and I'm going to be speaking with you today about hearing loss, hearing aids, and tinnitus. So let me share my screen a little bit before we begin. Okay, perfect. And can I just get away from someone if you're seeing my slides on the screen? Perfect. All right. So as an audiologist, audiologists are clinicians responsible for diagnosing and treating ear-related disorders like hearing loss and tinnitus. Today, we're going to be discussing hearing loss, hearing devices, how to know if you or someone you know could benefit from them. And we'll also talk a bit about tinnitus or ringing in the ears. And we'll be sure to leave plenty of time for questions at the end of today's session. I'll let Dr. Kozen pop on and introduce himself as well.
Sure. So good afternoon, everyone. My name is Elliot Kozen. As Emma mentioned, I'm one of the otologists and neurotologists at Mass Eye and Ear. For those that might not know about that specialty specifically, we are ear, nose, and throat surgeons, so otolaryngologists, and we have subspecialty training in ear, balance, and skull-based surgery. So patients that I see day in and day out have hearing and balance related issues. And this topic of hearing health is really very close to my heart. As was mentioned before, this is the picture of Mass Eye and Ear. It is quite literally attached to the Massachusetts General Hospital. It is a standalone institution, but it is a part of Mass General Brigham. So we're all sort of part of the same family, same medical records, and oftentimes everything is sort of interchangeable. So really happy to speak about this important topic today. So I'll just give everyone a brief overview of the hearing pathway. It is one of the most intricate and dynamic parts of the human body, but sort of wanted to get everyone on the same page. This is a schematic that you might see if you were to visit one of our offices. In this case, you see sound or musical instruments, which goes sort of through the ear canal. The ear canal is the part of the ear that makes wax. That sound is then captured by the eardrum. The medical jargon for eardrum is the tympanic membrane, and that vibrates. So the same way that sound would vibrate any surface, it causes the eardrum to vibrate. What you might not know is that the three smallest bones in the human body are actually in the ear, and those vibrate with sound as it's transmitted from the eardrum. And this is where it sort of gets exciting, because at the level of the inner ear, specifically the cochlea, this mechanical vibration energy is converted to electrical energy. Basically, it goes from electrical energy to the brain. So within about 2 square centimeters or so, you have sound from the outside world that's transmitted through an electrical impulse to the inner ear and the brain. And so we'll speak a little bit about how this influences different types of hearing loss.
So speaking of hearing loss, according to the Center for Disease Control, hearing loss is one of the most prevalent health conditions among adults age 65 and over, with about 16% or so of adults in the United States reporting hearing trouble. So that means that about 1 out of 5 men and 1 out of 8 women report they have at least some trouble hearing, making hearing loss about twice as prevalent as diabetes or cancer. So if you're experiencing hearing difficulties, you are not alone. Next up, Dr. Kozen is going to talk about the different types of hearing loss that we come across.
Right, so based on what I described in the previous slide, we can divide types of hearing loss into 2 different categories. So the first category, the medical term, is a conductive hearing loss. So examples of that are things like wax. If you have wax or cerumen in your ear and it's blocking the sound from entering the ear canal, that is a type of conductive hearing loss. Similarly, if you had fluid behind your ear, let's say you had an infection, often called otitis media, or you had a perforation or hole of your eardrum, similarly, the sound can't be transmitted to the inner ear, and that's also called a conductive hearing loss. The other type of hearing loss is what we would describe as sensorineural. That's a type of inner ear hearing loss. So common causes of inner ear hearing loss are things that we will all be familiar with. Aging. As we get older, the inner ear degenerates and we'll experience age-related hearing loss. And noise exposure. If you were to go to concerts, play an instrument, you're around gunfire, or say your occupation puts you around noise, like dentists or other providers or individuals who have noise exposure, that will result in an inner ear hearing loss. And so when you see us in the clinic setting, we'll try to differentiate a conductive hearing loss from a sensorineural hearing loss, because the treatments are often very different. And we'll work in partnership with our audiology colleagues to help better define this, because it's not often obvious based on the physical exam what type it may be. And the last type it could be is mixed. So many people might have both a conductive and sensorineural hearing loss.
So like Dr. Kozen was saying, in order to diagnose a hearing loss or obtain hearing aids, you should generally have both an otologic or ENT evaluation and an audiologic or hearing evaluation. For a hearing evaluation, that typically involves a tonal, or sometimes called pure tone, hearing test, where you raise your hand or press a button each time you hear a beep. And these beeps are presented at varied intensities and frequencies until your audiologist can determine the softest sounds that you can hear at several different frequencies. And these are called your hearing thresholds. So in addition to establishing your hearing thresholds, your audiologist will also determine your word recognition abilities by having you repeat a whole list of words at a given volume. So the tonal part of the hearing test allows us to determine how loud a sound needs to be for you to hear it. And word recognition testing helps us to establish how clearly you can process and understand those sounds. If you have a history of ear infections, ear surgeries, excessive earwax, or other middle ear problems, your audiologist may also perform a test called tympanometry, which is a quick pressure test of the middle ear system that can help us determine what type of hearing loss you may have.
Emma, maybe I could just jump in for just 1 second. So the analogy that I like to use with hearing testing is actually vision testing. We've probably all had our vision tested along the way. And so we look at a chart, of letters. So one part of the chart is, can you actually see what that letter is? And the second part of the test is, do you know what the letter is? So it's the same thing with hearing. It's like, can you hear a sound? And then do you understand the sound? And both of those are really critical in basically, conversation and speech. So think about these things somewhat separately. It's, can you hear something? And then do you understand it? Because those sort of are critical to functioning properly in terms of your hearing health.
Yeah, absolutely. And next up, we'll talk about when you should come in and have your hearing tested. So you should have a hearing test if you have been diagnosed with a hearing loss and it's been more than 12 months since your last evaluation. If you find that you're asking for repetition or saying what more often than you used to, you struggle to hear in difficult listening environments, such as at restaurants or when there's background noise, if your close communication partners, like your spouse, children, or friends, start to notice your hearing declining, or if you have bothersome ringing in one or both of your ears. Additionally, if you're interested in obtaining a hearing aid, you will need a hearing test that was done within the past 6 months.
So I can jump in here. So I often see many patients in the clinic setting who have hearing loss, and we can generally divide those into those where it happens gradually over time due to aging or they're exposed to a noise. But there's a very sort of separate group of individuals who experience a sudden hearing loss, say over the course of a few hours, days, or even a week or two. And this is what we would describe as an otologic or ear emergency. It is never normal to have hearing loss that occurs somewhat suddenly in one or both ears. People will often describe it might be due to allergies or a cold or an infection, and that very well might be the case. However, you should always see your doctor, whether it's your primary care doctor, an audiologist, or an ENT, just to make sure that is the case, because there are rare conditions of inner ear degeneration that is not due to a cold, it's not due to an allergy, and it's due to another factor. And oftentimes those are time sensitive in terms of treating those patients, often in the matter of days or weeks. So we want to see these patients as fast as possible. So the one analogy that I'll make to this is a heart attack. If somebody has chest pain, they know to dial 911 and go to the hospital. There's an equivalent condition for the ear that if you lose hearing all of a sudden in one or both of your ears, you should be seen right away because treatment is really time sensitive. So just think about that if you or another family member or colleague, friend has a sudden hearing loss. This is something that should be evaluated urgently. And I'll just add something, beyond the sort of sudden hearing loss that I mentioned, hearing is not just hearing. It's sort of a dynamic process where you're able to localize sound, be able to hear individuals in noisy environments. It has an immense impact on quality of life. And more studies are showing that hearing loss is associated with social isolation and cognitive decline, things like Alzheimer's and dementia. So hearing is not just hearing per se, really affects multiple areas of your life, and it's important to take care of it like you would any other medical issue.
And next up, we are going to start talking about some different types of hearing assistive devices, starting with hearing aids. So above, you'll see some examples of many different hearing aid styles, ranging from pretty small in-the-ear devices to more powerful behind-the-ear technology. Hearing aids come in many different sizes, styles, and strengths. They can have disposable batteries, and more recently, they can even have rechargeable batteries inside of them. These devices are typically intended for daily use, meaning they're meant to be worn during the day, not at night, and are not typically waterproof, so should not be worn while swimming or showering. Most behind-the-ear hearing aids and some in-the-ear hearing aids also have Bluetooth streaming capabilities. So this means that if you use a smartphone, hearing aids can be paired to your smartphone for call or audio streaming, just like a pair of Bluetooth headphones, which will allow you to make hands-free phone calls. Most newer hearing aids also have a corresponding smartphone application that goes along with them. And this allows you to control the hearing aid volume and programs right from your cell phone. So we've certainly seen hearing aids become more user-friendly and easy to integrate into your life over the last few years. There are also such a thing as surgically implantable hearing devices. So surgically implantable hearing devices are meant to target and treat certain or specific types of hearing loss. A cochlear implant, which you can see pictured on the screen, is a type of hearing assistive device that can be used for people with severe or profound hearing loss that have poor word understanding. So essentially, these are devices for people whose hearing loss may be too severe for them to be able to use a standard hearing aid. And these devices have many of the same features of standard hearing aids, like rechargeable batteries and cell phone compatibility. And as you may have heard, the FDA has, over the last few years, approved over-the-counter hearing devices. So these devices tend to look really similar to a traditional hearing aid. You can see an example of an over-the-counter hearing aid here. But they are a bit different because they often can't be quite as precisely fine-tuned for a specific person's hearing loss. So purchasing hearing aids online or choosing over-the-counter devices can sometimes be a less expensive option, but it can also sometimes be the least customizable option. So these types of devices can be a good solution for less complicated hearing losses or non-medically involved hearing issues. Next up, we'll talk about remote microphones. So a remote microphone is a system in which a small microphone, which I'll circle my mouse around here or here, is worn by the person speaking, and receivers are worn by the person listening. So remote microphones are often an optional accessory that can be paired with hearing aids in order to improve the signal quality when you're in background noise. So these devices are particularly helpful for one-on-one conversations in noisy settings. For example, dining at a loud restaurant with a family member or a friend. Additionally, a lot of patients report just the simple act of having the talker speak into the little remote microphone often serves as a reminder to them to speak more slowly and more clearly so that you're able to hear them a little bit better. But remote microphones are just one example of the many, many different types of accessories that can be paired to hearing aids. There are actually very similar accessories that can be plugged right into your television set in order to send the television volume directly to your hearing aids as well. So as you can see, there are lots of factors to consider when you're choosing a hearing device. And of course, your hearing loss always comes first. However, we want to look for a hearing aid that fits well into your lifestyle. So if there are any sort of vision or dexterity issues, those should definitely be considered when we're picking out a hearing aid. I wouldn't want someone to end up with a great hearing aid that really helps them, only to find that the batteries are just too small for them to see or to change. So while the degree of hearing loss often plays a big factor in the size of the hearing aid you may need, your cosmetic preferences matter as well. Hearing aids are meant to be worn daily, so it's important to pick a style that you feel comfortable with. Additionally, certain styles and types of hearing aids have different kinds of Bluetooth or wireless technology. So if that's something you're interested in, you may find that you select a particular hearing aid based on the type of cell phone that it's compatible with or the accessories that you're interested in using with the devices. And next up, I want to talk a little bit about tinnitus, starting with some background information. So tinnitus, or ringing in the ears, refers to perceived sounds that have no external acoustic source, meaning it's just a sound you hear in your ears, not one that's coming in externally. And descriptions of tinnitus can be a really wide range of auditory sensations. It could be ringing, buzzing, pulsing, clicking, whooshing. And these sounds can be constant, they can be intermittent, and they can vary at really any time. And the reason I wanted to talk about tinnitus today is because more than 45 million American individuals experience tinnitus. So that means about 10 to 15% of all adults experience some form of tinnitus. And of these affected adults, the majority experience tinnitus that is not bothersome to them, meaning it doesn't affect their nightly sleep schedule or their day-to-day activities, and usually does not cause them to seek any specific treatment. But the remaining percentage of adults experience tinnitus that can interfere with their sleep, concentration, daily activities, and does cause them to seek treatment. So right now, the exact causes and mechanisms of tinnitus still remain pretty largely unknown. However, tinnitus has been linked to several factors, including hearing loss, noise exposure, age, psychosocial status like stress and depression can contribute to tinnitus, ototoxic medications, vestibular schwannomas, which is a type of growth on the auditory nerve, and many other medical issues, including Lyme disease, high blood pressure, ear infections, and TMJ. But currently, the working theory of tinnitus source is that it's ultimately what we call multifactorial, meaning there's multiple interactions from different systems that cause tinnitus. And one of the things you may find yourself discussing with a provider are the effects that tinnitus can have on your well-being. So some really commonly reported effects of tinnitus include a significant impact on a person's attention, sleep quality, concentration, and emotions. An example of this would be feeling like you have less attention to devote to the things you want to because you're allocating a great deal of your mental resources to tinnitus. So tinnitus, while it's not directly harmful to our physical health, can certainly cause significant emotional distress. And like we said, at present, there is no specific cure for tinnitus. However, there are lots of management techniques that can help to make it less bothersome. So these management techniques tend to focus on habituating to tinnitus or getting used to tinnitus, meaning changing the way you react to it. So some common goals of tinnitus management are to feel less stressed about tinnitus, have fewer emotional reactions to it, think about it less, feel like it has less of an effect on your daily activities, and to feel as though tinnitus is just not much of a problem in your day-to-day life. So how exactly do we do that? Mass Eye and Ear Audiology Department does offer some online group classes. They're conducted over Zoom, similar to today's session. And these sessions focus on tinnitus management and habituation. So these programs use informational counseling, and they recommend sound therapy to help manage the bothersome aspects of tinnitus. So informational counseling is educational information learning about tinnitus, and sound therapy is the use of external sounds to change the reactions to tinnitus. So just one example of sound therapy would be a person with bothersome tinnitus using a fan or a white noise machine to help them fall asleep at night. And there are lots of other ways that you can use sound therapy to help manage tinnitus and make it less bothersome to your daily life, all of which you can learn about in the virtual group sessions or by talking directly with an otologist or audiologist. And I hope that you found the information that we talked about today helpful. Dr. Kozen, unless you have anything else to add, I think we can turn it over to the audience for some questions.
I think that sounds great. Happy to address any questions that the group has.
Great. We have a lot of questions, but before we go to the questions, I just want to go back to Dr. Russell, because we can't ever have a town hall without talking about COVID. And he's got a quick COVID update.
I do. Thank you so much. And maybe if we could stop sharing now, I think we're good, right?
Yep.
Yeah. So I just wanted to this sort of fresh off the presses. I know that we all saw in the news today that the court order effectively ended the CDC's order for masks on public transportation and transportation hubs. And while Ubers and airlines have gotten rid of this, the CDC is not going to enforce it, but does continue to recommend that people wear masks in indoor public transportation settings at this time. Additionally, folks who are over the age of 50 and are at least 4 months out from their first booster are eligible to get their next booster. So just wanted to make sure we stayed up to speed on that. Thanks, Susan.
All right, thank you. So just to turn to the questions, I'm just going to go through these as they came in. So the very first one is, Dr. Kozen, can you say something about the success rate of implantable hearing devices?
Yeah, and I'll probably have Emma help me out with this as well. So we generally categorize hearing assistive devices into those individuals that have serviceable hearing, meaning that they need a hearing aid, and those where their hearing is so severe that no hearing aid is going to help, and that's sort of a cochlear implant. So I just want to make an analogy, because a lot of people don't really understand like what that means. How could you hear something but not understand it? And the best example that I can use is if you were to be in your car and use an old school FM radio, not satellite radio, but FM, radio. And as you drive further away from the radio station, or you're listening to NPR or music, all of a sudden you can hear something, but you can't understand the words. And so what do? You turn up the volume. However, at a certain point, the volume will be so high, but you still cannot understand the words. And so that's when basically hearing aids no longer work. So when we think about hearing aids, it's generally turning up the volume so that you might understand things a little bit better. And the vast majority of hearing aids are ones that you take on and off your ear when you go to sleep or you go in the shower. There's a very small portion of implantable hearing aids that people might get for very specific reasons. Oftentimes it's because they've had prior surgery, or anatomically they can't use a standard hearing aid, or other rarely they just like the quality of it. Those hearing aids are sort of like, if anyone has ever used bone conduction headphones, they basically vibrate and provide sound in a slightly different way. And the success rate is really highly variable based on the individual. I can't give you like a percentage, but it just depends on the individual person and why they have it. The other category are the implantable hearing aids or hearing devices that are cochlear implants. And those really are incredibly successful. Those are, by and large, the most successful neuroprosthetic device. There are probably 500,000 individuals worldwide who have received one, and they really do improve quality of life. So if you qualify for a cochlear implant, because usually both your ears are so severe that you can't have a hearing aid, then you would likely do quite well. So that was a little bit of a long-winded response. Emma, do you have anything else you'd like to add to that?
Yeah, I would just add that cochlear implants are, per patient report, a very different way of hearing than a hearing aid. So a hearing aid allows you to hear using an acoustic signal, like Dr. Kozen was saying. It turns the volume of the sound up, whereas an implantable hearing aid, like a cochlear implant, is surgically implanted into your head, but you're not actually hearing acoustics being presented through your ear. The sound is being conducted through a processor worn on the outside of your head. And things do sound more electronic than they do with a standard hearing aid. However, for people whose hearing loss is too severe to be helped by a standard hearing aid with an acoustic output, the next best thing is certainly that more electronic output from a cochlear implant.
Thank you. We have a lot of questions about tinnitus, and one quick question from me is, could you maybe put information about how to access or join the virtual sessions that you mentioned in the chat?
Yes.
I think that would be very helpful for people.
Yeah.
So one of the first questions is, isn't tinnitus in the brain, not the ears?
So maybe I could jump in here and add a little bit of flavor. So that's a great question. And we don't really know. And it sort of becomes an existential question of, how do you hear? Do you hear with your brain, or do you hear with your ears? And it's a little bit of both. So the way that I generally explain to my patients some of the mechanisms of tinnitus is, it's sort of like a radio analogy, but the way that I tend to think about it is, you have sound that comes in through your ear that your brain then processes. And then oftentimes that signal, that sound, the quality that's reaching your brain is not as good. So whether you have a hearing loss or another reason why that signal is not going from your ear to your brain, the quality of that is either poor, degraded, or in some circumstances, absent. So the brain is looking for that signal. It's saying, like, come on, ear, like, give me the signal that I want so I can understand what's going on, but nothing's going in. And as a result, the brain is sort of making up its own sound. It's almost like a phantom noise. And an example of that would be like if anyone watches TV and has a cable box. If you put the TV on and the cable box is not attached, you just get snow, right? You just get, a blank screen with some random pixels on it. And it's the same thing with tinnitus, is the brain is like your TV and your ear is like the cable box. And if you're not getting a good signal, the brain is just going to make something up. And so I think that's sort of how we think about it, at least in 2022.
Okay. There are other questions. And so where can people look for studies on tinnitus? And I'm hoping that maybe there's information on the Mass Eye and Ear website. And also, where can people get information about who to see about this at Mass Eye and Ear? And so if there are places or websites that you can post about that on the chat, I think that would be really helpful. But I also want to see if either of you want to say something about that.
Yeah, so I can start. In terms of looking for studies or just general information on tinnitus, I know trying to do some online research, you can, run into quite a few false claims or, hefty promises, promising cures for tinnitus and all these different management options. So it can certainly be overwhelming to find out where you can get reputable information. Some of the sources that I really like are the American Tinnitus Association website. It's ata.org, as well as the IDA Institute website. That's IDA Institute website. They both have great information on tinnitus, kind of current best practices for managing tinnitus, and as well as some information of, how to get involved in tinnitus groups or research opportunities in your area.
Okay, thank you.
Maybe I could add a quick short story, a little color commentary related to that. So as Emma mentioned, if you Google tinnitus, you're going to get a lot of good data and a lot of good studies and a lot of not good data and scary studies. And just be careful of what's online, because there will be a lot of websites claiming to have the solution to tinnitus. So I'll give you this one example, and I don't think this is a violation. We'll just say it was Mr. and Mrs. Jones came to my clinic one day, and the reason was that Mr. Jones bought pills online for $800 that claimed to treat tinnitus. And Mrs. Jones said, "Can you please have my husband return the pills online?" So this wasn't even about tinnitus. It wasn't even about hearing loss because they both knew all of it. I was a marriage counselor trying to, create some sort of consensus on what Mr. Jones had purchased. And I will just say that at the end of the conversation, I told Mr. Jones that he really did need to return the magic pills. So don't buy magic pills online. I guarantee you they will not work and they're potentially dangerous. There is no medication in the United States that is approved to treat tinnitus, despite what any website says. So please see an audiologist, your primary care doctor, an otologist before you, spend money on a potential treatment.
Thank you. That was very helpful. So one last question about tinnitus, and that is, can it be related to neck issues? And is it possible that a hearing aid may actually help?
So I'll address the hearing aid part of the question. The answer to that is yes, a hearing aid can certainly help with tinnitus. It does not, eliminate tinnitus or make it go away completely, but it does often help to reduce the contrast of tinnitus. So what I mean by that is if you have hearing loss and you have tinnitus, your hearing loss is often filtering out some low-level background sound. And then when you're in a quiet room, the only thing you may be hearing is your tinnitus and the quiet room. What a hearing aid does is it reintroduces all of those ambient sounds and soft sounds that your hearing loss may filter out, so that when you're sitting in a quiet room, the only thing to hear is not just your tinnitus. So the contrast of tinnitus to quiet room becomes a little bit less.
Great.
I can address the second part of that question. So you have to think about tinnitus as not a diagnosis, but a symptom. So if somebody says they have knee pain, the pain isn't the diagnosis. There's something else going on that's causing that knee pain, and it's up to the clinicians to figure that out so that we can best treat it. So hearing loss, noise exposure, those are all causes of tinnitus that could be treated with things like hearing aids. However, there are a litany of other causes of tinnitus, whether it's neck or jaw issues, migraines, intracranial issues, blood vessel issues. And so it's really our job as providers to make sure that you don't have any of those other causes of tinnitus before you're treated just sort of blanketly with a hearing aid. So again, tinnitus does require a workup. It's not a one, size fits all type of approach. So really encourage you, if you do have it, to see your medical provider so that we can potentially figure out what might be causing it.
Thank you. A very important question. Are hearing aids covered by Medicare?
I can take this one. Unfortunately, the answer to that question is no. Hearing aids are not currently covered by Medicare. I will say certain Medicaid plans do cover some hearing aids, but it is common for insurance companies to not cover hearing aids. So, a lot of people tend to shop around at different private practices, clinics, and hospitals to find either a provider that their insurance is contracted with, or a provider, with a price of hearing aid that fits into their budget and lifestyle. So unfortunately, no, Medicare does not cover hearing aids.
I'm going to ask a question that I don't think is in the chat that is related to that, because I've heard a lot of talk in the community about Costco's hearing aids and how they in general are pretty good. Can you say, and I think they're much more reasonable than hearing aids that are available at some other sites. Can you say something about that?
Sure. So what I would always recommend when shopping around for a hearing aid is to get a hearing aid that can be verified by a hearing health professional, ideally a doctor of audiology. So the hearing aids that they sell at Costco are sometimes physically the same brand or type of device that you would get elsewhere at a hospital, at a private practice. What I would look for is to ensure that the settings of that device can be verified to fit your hearing loss. So when you're seen at a hospital like Mass Eye and Ear, we actually put a small microphone inside your ear when we're programming your hearing aid. And we very precisely fine-tune the hearing aid to match your most recent hearing test at every single different pitch. So that's not to say that, the hearing aids that they sell at Costco are not good pieces of technology, but I would say no matter where you're going, you would want to ensure that you can have the hearing aid verified right on your ear, which is not something that I can guarantee that they do at every place that sells hearing aids.
Okay, thank you. So another question that I think is very important for all of us, and that is, what tips do you have when a family or friend has a hearing loss? And I can say, just in my own experience with older relatives who clearly had a hearing loss, it was often very difficult to convince them that they had a hearing loss until it was quite profound.
Yeah.
So can you say anything about that and how to help people with that in a way that is supportive and empathetic?
Sure. So first and foremost, if the person is receptive to it, I would certainly recommend having them come in and have a hearing test. But in terms of just, facilitating better communication, I would say, if you're speaking to someone with a hearing loss, try facing the person directly in good lighting. Avoid talking to them from another room, like yelling to them from the kitchen when you're in the living room. Avoid having important conversations at a time of day where the person might be feeling tired or sick. Try to speak naturally. It's much more important to speak slowly than it is to just shout or speak loudly. You want to ensure your words aren't getting mumbled together. In the same vein, try to avoid eating, chewing, or covering your mouth while you're talking. And additionally, a tip that I love to give my patients is, if you find yourself struggling to hear in a conversation, rather than continuing to say, what, could you repeat that? It's always a good tip to ask the person that you're talking to if maybe they could rephrase what they're saying. By asking another person to rephrase what they're saying, not only are they going to kind of pause for a second to think about how they want to rephrase, they'll oftentimes slow down their speech, and you'll get a few more context clues in that new rephrased sentence to help facilitate better communication. So lots of things that you can do to still communicate with someone with a hearing loss, but certainly recommending a hearing test.
Thank you.
The one thing, if I might just add a little bit, is oftentimes people say, "Oh, I can hear just fine." And they often can, except when you bring them in a noisy environment. And that's when really things start to break down. Is it's fine one-on-one if you're at home across the dinner table to say, "I can hear no issues," but you have to sort of provide examples about when they can't hear. And then oftentimes they're sort of just sitting silently on the other end of the table, often smiling or nodding. And I know, because I'm a hearing health provider, that they're not hearing anything. They're just trying to look like they're participating in the conversation, but what they really are is isolated and really not participating. So I'll make the argument or tell my patients to say, explain to them that they're not participating because they can't hear. The hearing is so that you could participate and understand what's going on. The other argument that I'll often use is that it's exhausting not being able to hear. You have to pay attention, you're staring at people's faces, you're trying to read lips, you're trying to back out background noise. And so at the end of the day, you're just fatigued because of the amount of time and energy that you had to spend listening. And so I'll often say, look, if we can get you 10% more energy back at the end of the day because you're using hearing aids or you're not so exhausted, it will probably make a huge difference in your quality of life and those around you. So again, going back to the slides, hearing is not just hearing, it's everything else that goes along with it. So you have a little bit of ammunition in your tool belt to sort of make this argument to your colleagues. And
That is
family.
incredibly helpful advice. Thank you. So there's another very important question about devices that help people hear televisions. And if you look in the chat, there's a long question about a particular device, the super ear personal sound amplification. And I'm wondering if you have recommendations about devices that people can use to hear the television or other things, and actually whether Mass Eye and Ear actually has a store where you can actually get access to these.
Yeah, so the device in question was the Super Ear Personal Sound Amplification, which, in case any of you are not familiar, is a headset that is worn, and it has a wired connection to a little microphone box that a person can speak directly into the microphone box, and it will send the signal to the person wearing its headset. And it seems like this person was trying to use that system pointed towards the television to better hear the television, which is a great thought. However, it seems like there was lots of other sounds in the room that were also being amplified in that case. So there are certainly designated television-specific hearing solutions. One of the more popular is something called TV ears. To answer your question, Susan, Mass Eye and Ear doesn't have a store directly where you can purchase these hearing assistive devices, but we do have lots of handouts and recommendations, and would be more than happy to give anyone a recommendation on where they could get the devices. As for TV ears, they can be purchased at most electronics stores. And it's essentially a small box that would plug into the back of your television and a headset that you would then wear, and it would send the television volume directly to your headset while still allowing the television volume to come out of the television at a volume comfortable for everyone else in the room. So to answer the question in the chat, I might recommend switching from a kind of microphone box that picks up ambient room sounds to like a direct television to headset type of technology.
Okay, thank you.
Yeah.
There's another question that's more clinical, and it's about, does the position of a person's head, lying down, bending over, and hearing a whooshing, pulsing sound determine the cause or type of treatment? And I assume it's around hearing loss.
I can address that. So I think this goes back to this concept of tinnitus and the causes of tinnitus. So tinnitus can be whooshing, clicking, sounding like gears grinding. It comes in all sorts of flavors. And so when I hear that sort of story with positional change in hearing that is maybe associated with blood flow and neck position, to me that means that you should see a provider to try to understand what that might, the cause of that be. And generally the workup of tinnitus, besides a hearing test, is often imaging. Sometimes it's a CT scan, a CAT scan, sometimes it's an MRI. It just depends on what the full history is. So again, I think this goes back to the original point where tinnitus is not normal. It's common, but it doesn't happen in everyone. And if you have it, you should be checked out for it, starting with a basic exam and then probably going on to a hearing test and then deciding what to do based on those data points.
Okay. Can you all say anything about what is a reasonable price for a hearing aid? I think that's a bit challenging to answer because there are different types of hearing aids and whatever, but can you just make any comment about that?
I would say it is very, very wide ranging. Over-the-counter hearing aids, like we said, those kind of less customizable hearing aids that really aim to just kind of give you a volume bump. Those can start at a couple $100s. Most standard hearing aids tend to cost around a few $1,000s, I would say on average between $3,000 to $5,000 or $6,000, depending on, what kind of place you go to and what kind of devices that you pick out. And then surgically implantable hearing devices are often covered by insurance because they cost tens of thousands of dollars. So it really does range from a couple $100s to tens of thousands of dollars, depending on what you need.
Okay. Is there an advantage to get a hearing aid when you have mild to moderate hearing loss, rather than waiting until you have much greater hearing loss? Can you say a little about that?
Yeah, that's a great question. I would say definitely there is an advantage. Like Dr. Kozen was saying, there have been a lot of recent studies linking hearing loss to potential cognitive decline and social isolation. So even with a mild to moderate hearing loss, we know that when people don't hear as well, they don't want to do as much. They don't want to be as active of a participant in their own lives. So any sort of, thing that you can do to help yourself hear better and help avoid any of that social isolation that comes along with hearing loss, I think is great.
All right, thank you.
And just from a geriatrics perspective, underline, highlight, exclamation mark. We also talk about social isolation, cognitive impairment, and then also falls. Because remember, when we're trying to orient ourselves in space, we need optimal vision and hearing to get through things, especially if we have to get up at night to go tinkle. So just please, yes, underline that. Thank you.
And Dr. Russell, I think we're going to close out with you with another COVID question. And that is, can you say a little bit about mixing and matching the vaccines? So if you've had Pfizer, is it okay to get a Moderna booster, et cetera? I think you know what the question is.
Yeah. So my understanding from the research is that if you've received an mRNA vaccine, that should be your booster. So whether you get whether you get Pfizer or Moderna, there's some theory. They're doing research on it now to see is there additional immune response if you mix and match. And the preliminary stuff seems to be that there is, but as long as you're getting the mRNA vaccine, not the Johnson & Johnson, I think is the message.
Okay. I think we may have covered most of our questions. I just need to go back and double check. There's one about the VA services. Can somebody say something? Sharon, do you want to say something, or Matt? I know you know a little bit about the VA. Can you say something about the VA services for hearing aids or things like that?
I wanted to ask Emma about that because many veterans swear by going to the VA because of the cost effectiveness of getting even cochlear implants there too, and hearing aids themselves.
Yeah, so if you have a service-connected hearing loss, the VA will often provide hearing loss to veterans at no cost. So if you're a veteran with a service-connected hearing loss, I would definitely have the VA be one of your first stops when you're shopping around for hearing aids.
Great.
One other thing I'll just add briefly on selecting a place to purchase a hearing aid is I had a mentor that once said that hearing aids don't work if they're in the sock drawer. And so what he sort of meant by that was manyfold, but one of them is that if the hearing aid breaks or a piece becomes missing or there's a missing battery, you don't necessarily want to have to travel 3 hours to the one place that you thought was fantastic to buy the hearing aid. You want to do somewhere that's relatively local. So think about that too. Like, this is a really highly tuned instrument. It will occasionally need servicing. So think about that too, where you purchase it. And Mass Eye and Ear and other places might service other hearing aids, but let that at least be part of your decision making.
Okay. We have one question that I'm not sure I entirely understand, but it is, does a hearing aid with an app allow, or how does the hearing aid with an app differ? Is it better? Can it be tweaked for different situations?
So I would not say that it's necessarily better than a hearing aid without an app, but it does make it a little bit easier to switch between volumes and program settings. So most hearing aids have small little buttons right along the back of them that allow you to do the same thing that an app would. But if you have any sort of dexterity issues or don't want to have to fumble behind your ear to change the volume of your hearing aid, some people find it nice and easy to just adjust the volume on the app. So in terms of your actual hearing performance, no, it's not going to make you hear better necessarily, but it may be easier for you to change the settings.
Okay, thank you. Thank you, Dr. Kozen, and thank you, Ms. Alsher. I've learned a lot today. This has been incredibly informative, and I think I'm going to run right out and get my hearing checked. So thank you so much. And thanks to everyone who joined us today. And we're hoping to have a session coming up on things that help us with our balance and our mobility, kind of in the same vein. So stay tuned and we'll get more information out soon. And we hope you have a wonderful rest of your day. Dr. Russell, Dr. Levine, any last comments?
No, I just am so grateful to Emma and Elliot. This was just exactly what we were hoping for. Good practical knowledge from the people who do this day in, day out. So thank you very much. And everybody hopefully enjoy the sun has finally come out.
And this is
Great.
Bread and butter for geriatricians. And I'm not surprised there are that many of you on our call today. And yes, I just wrote to Dr. Kozen and said, I can't tell you how many hearing aids I found in the sock or underwear drawer. It's always the top drawer in the dresser.
That's right. Safekeeping.
Thank you all.
Thanks, everyone.
Have a great day.
Bye-bye. Thanks.
Bye-bye.